Now it's my pleasure to introduce our next speaker, and our next speaker is George Hanna. And we've been discussing endoscopy so far, but as you can imagine, it's extremely difficult to deal with some of these tough esophageal cases without having an expert surgeon, alongside with us. So George is head of the Department of Surgery at Imperial College, and he's an upper GI surgeon at the Imperial College NHS Trust. So George, welcome to the webinar.
Thank you very much for the opportunity to take part in this seminar. So this is a very low-tech talk compared with the previous two ones. So I'm going to talk about a role of surgery in early Barrett's cancer. So I thought that maybe first start just try to define what is early cancer in Barrett. So looking at the literature, majority of people look at early cancer as the cancer confined to the mucosa or submucosa of the esophagus with no evidence of spread. And some publications define the early cancer is only limited to the mucosa. The definition of no spread, of course, is not clear because it could be going to the lymph node with the submucosa, which I'm going to talk about. So this is TNM, the 8th edition, which T1A is the mucosa and T1B is going to the submucosa. Now, clinical, that TNM include the distinction between clinical and pathological staging. For the clinical staging is T1, whether without lymph nodes will determine whether it's a stage 1 or stage 2A. But in pathological definitions, so T1, A, B, C, which really is the T1 disease with no lymph nodes. When it goes to lymph nodes, this will be 2B. And this is makes a difference in the treatment, because whether the Barrett's cancer goes into the submucosa will determine really the lymph node incidence. So what is the indication surgery? In broad terms, the indication in surgery is that T1B, because we have about 15 to 20% incidence of lymph node metastasis, and the dysplastic esophagus, which is not amenable to endoscopic therapy. So dysplastic Barrett's is really an endoscopic therapy treatment, and if it doesn't work, then we'll go to surgery. But the first really call will be for the endoscopist. Now, I looked at the clinical trials to see what is happening in terms of registered trial for surgery for Barrett's. And the only one I found, unless I missed some, I know there are talks about doing trials for T1B, but for registered trial, the only one I registered I have seen is the one is an observational study in 5,000 patients for Barrett's treated with endoscopy and with surgery. So if we talk about surgery for a T1B or surgery for stage 2B, which is T1 with lymph node spread. I think before talk about surgery is to talk what is the aim of surgery. So the aim of surgery would be, as any cancer surgery, is the long-term survival, the local control of the disease, and to remove the entire Barrett's segment. And although this classified as an early Barrett's cancer, and now I'm talking about long-term survival. But if we look at the incidence of lymph nodes, this is big data series and an observational study, which showed for T1A and T1B, although the outcome is similar, this is an American data set, but the incidence of lymph nodes for T1B is about 15%. Now, if we look at the TNM8 survival curves, so the top three, this is the T1 stage 1A, and the one with an arrow is a stage 2B, and stage 2B is the T1N1 disease, and it shows clearly a survival difference between 1A and 2B. So the lymph nodes in the associated with T1B, which in about 15 to 20% of patients, will make a big difference in survival, long-term survival. And the same for local regional recurrence. This is a recurrence-free survival. Again, the top survival curves for 1A, and the one with the arrow is 2B, which again is the one with the submucosal with lymph node metastasis. So in both of, so when the early Barrett's goes to the lymph nodes, which is likely between 15 to 20% of patients, this will change the survival and the local regional recurrence significantly. And that's why an EMOV surgery still works on the long-term survival and local regional recurrence. Now, we just need to look at the pooled analysis for EOS. There's different papers. There's a couple of meta-analysis that show that the sensitivity and specificity is not perfect. So for T1B with lymph nodes to depend entirely on endoscopic ultrasound, need to be cautious about it because it is not perfect, and at the same time, it's less accurate in early disease. Now, we know the long-term survival, which is important for 2B, determined on the quality of the lymphadenectomy, and this is an international study which showed that the number of lymph nodes or the quality of surgery will determine the long-term survival. Now, so for surgery for 2B, I think the standard of surgery would be, is the standard, because it's an adenocarcinoma, is the IV-Lewis oesophageectomy for lower esophageal adenocarcinoma with 2-field lymphadenectomy. Occasionally, we need to do a total oesophageectomy for cancer with a long segment. And sometimes with this group of patients, if it is a multifocal and the tumor in the upper end of the Barrett's segment, then we will need a 3-field lymphadenectomy with clearance of the neck lymph nodes. Now, a couple of words about dysplastic Barrett's. So this is, is really a call, as I said, for the endoscopist. It is done in a multidisciplinary team. If they think that the segment is too long for endoscopic therapy or is an ulcerated lesion which cannot be removed, or the failure of the endoscopy to eradicate dysplasia. Now, for dysplastic Barrett's, there is less emphasis on lymphadenectomy because this is not an operation has been done for long-term survival or local regional recurrence. So absolutely the primary aim for those is to eliminate the Barrett's segment with the dysplasia is usually always high-grade dysplasia with it. Now, the approach for it, whether it will be a 2-stage or a 3-stage, with a 3-stage anastomosis in the neck, if it is a very long segment, which require the entire esophagus to be removed. And this is unusual, but they do happen. So just to conclude a surgical approach for early Barrett's cancer. So for surgery for 2B, this is a two-stage oesophageectomy and two-field lymphadenectomy with a total oesophageectomy if it is a long segment. So we can do a two-field lymphadenectomy in the abdomen and the chest, and anastomosis in the neck if it is a long segment, or do the anastomosis in the superior mediastinum if it is a short segment. Now, the dysplastic segment is a 2 or 3 stage depending on the length of the esophagus. Thank you.
George, thank you very much for that simple yet elegant presentation. And I think it really brings to the forefront some of these issues that we see every day in practice. So Jacob has a question, and his question is, what's the indication for surgery in long segment Barrett's esophagus? And evidence is that without a visible lesion, the invasive cancer risk is 5%. So I guess it's high-grade dysplasia in a patient with a long segment of Barrett's esophagus without a visible lesion. What's your approach, George, in that situation?
We usually, for a long segment alone is not, it's the dysplasia with a long segment, which really the endoscopy cannot remove. If the endoscopist can remove the dysplastic Barrett's, this will be the first choice. So we just do it as a plan B if the high-grade dysplasia cannot be removed. But a long segment alone Barrett's without dysplasia, we don't operate on them.
Right. Absolutely. So, George, if I may just push you a little bit on that. So let's just say that there is flat high-grade dysplasia in a patient with, an 8 centimeter long Barrett's esophagus. And if that patient came to you, George, I mean, would you offer endoscopic therapy in that situation? Or would you say that this is too long for endoscopists to deal with and go directly for surgery? How do you deal with that in your institution?
Yeah, we discuss them in our multidisciplinary team meeting with the endoscopists there. Usually they have the first call if they think they can clear the high-grade dysplasia and deal with eradicate the rest with radiofrequency ablation. This will be the first choice. Okay, we don't perfect. Do surgery for high-grade dysplasia unless the endoscopist cannot deal with it.
Thank you. There are 2 questions related to T1B and T1N plus node positive disease. And the question for you is, in superficial disease, and I think you can see it, George, on your screen as well, what's the accuracy of PET, EUS? What do you do? Do you perform both or just one of them? And how do you deal with those patients?
So for people, we do endoscopic ultrasound with them, and we do PET for them. Now the accuracy, well, the question with endoscopic ultrasound that it can say N1 disease. You don't know what is the N1, what they've seen in the endoscopic ultrasound, or whether the one you removed, unless you have an endoscopic biopsy from it. So whether you say it's an overall accuracy or other accuracy per lymph node stations, we really very difficult to determine. But if one have a T1A, then they go for endoscopy. If for a T1B, then we go for surgery. Whether if it goes to the submucosa in our institution, it goes to surgery straight. Whether we don't go for the endoscopic ultrasound and PET scan to determine surgery for T1B. T1B, we go for surgery. Okay. Occasionally, we get patients who are very, very, very unfed. Then we can always do endoscopy and yes.
Thanks. Question from Ken Wang is that in a CWER 3 junctional cancer, what's your approach? Is it still a Ivor-Lewis procedure?
No, no. Type 3 really is a gastric cancer. So type 3, we do an extended total gastrectomy, we do a total gastrectomy and lower esophagectomy. If it is within a couple of centimeters of the junction, we can do it from the abdomen. If it goes more than that, we go do a left thoracollaparotomy and do total gastrectomy and lower esophagectomy. Type 3 is really a gastric one.
Okay, perfect. We'll handle a couple more questions here. This is an interesting one that endoscopists, look at as well, is anti-reflux surgery when endoscopic therapy is being performed. There's a lot of sort of controversy about it, is that, the surgeon or some surgeons, I would say, are firm believers that unless you control the reflux, your endoscopic therapy is not going to be that successful. So what's your approach, George, and what would you like to tell the audience is that, where do you stand on that? Should all patients undergoing endoscopic therapy get a wrap?
So let me just first say, we know from a population-based study, we have a paper which published in Annals about it, which, and other people from Sweden published as well. So people on a population-based study, the risk of people who progression of Barrett's with reflux disease, it still is there, but it's still small and only detected because of population-based studies. So there is a risk and it is small. From an evidence perspective, we don't have data to tell us in a very respectable sample size and high quality data to tell us that doing anti-reflux will improve the outcome after resection of high-grade dysplasia. So if I'm going to speak about hardcore evidence, really we don't have. So we don't do anti-reflux surgery to prevent the progression of Barrett's in our institution, although we know that if you get a very big number, you may find a difference. But if a difference, if you really need a national number to find it out, it's too small. So we don't. But I can see the point of that.
Okay.
But to do a study, Giovanni Zanonotto looked at to do a study, and the number to be done is just immense to prove the point. So that's why we didn't do it.
Okay. Thank you very much, George, for your wonderful presentation and your very clear answers to this. There are 3 additional questions. If you wouldn't mind just going and responding to them, I think that would be great.